Welcome to Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. Featuring thought leaders from leading institutions across the globe, this series of conversations unveils the power behind clinical algorithms and decision support tools, and how they are changing the way we diagnose and manage cardiac conditions. From their impact on clinical practice, their benefits for patient outcomes, and the challenges they pose to health systems in terms of implementation and regulation, this podcast is intended as a precious resource for healthcare professionals in cardiology and emergency medicine who are curious to learn more about this exciting field. I'm your host, Matthew Chaffert, and you are listening to Cardio Insights. So welcome, Professor Giannitsis, to this episode of Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. So for our listeners who might be new to you, you are an assistant professor of medicine at the University of Heidelberg in Germany, where you serve as a senior physician in the Cardiology, Angiology, and Pneumology Clinic. You are also an attending physician in the chest pain unit and research group, leader for the Cardiac Biomarker Group, leading as well the chest pain unit initiative of the German Society of Cardiology, and presiding as the chair of the certification committee for chest pain units. So throughout your career, you have co-authored more than 600 publications where you focus on cardiac biomarkers and their use in diagnosing coronary syndromes. You also specialize in cardiac magnetic resonance imaging, heading a research group that's interested in combining biomarker information with phenotypes from imaging. So in this episode of the series, we want to explore with you how digital algorithms can be used for the timely recognition and management of acute coronary syndromes in the emergency department, and the impact of these algorithms on reducing treatment delays, improving risk stratification, and guiding appropriate interventions. So for our listeners who might not be experts about acute coronary syndromes, can you give us an overview of what these conditions represent and also of their causes?
First of all, thank you very much for inviting me here. The acute coronary syndrome is worldwide a leading cause of hospital admissions. And in fact, many countries face enormous problems with the numbers of patients who are admitted to emergency departments, and only a fraction these patients then in the end will end up with an acute coronary syndrome. And this is our daily challenge in clinical practice, to sort out who has an acute coronary syndrome, and then to find out what specific entity is within this spectrum of acute coronary syndromes. And just to briefly highlight for those who are not familiar with acute coronary syndromes, acute coronary syndromes is a term that is comprehensive, including patients with ST segment elevation, myocardial infarction, who are not the scope of biomarker testing. Okay. Here the diagnosis is made by the EKG, and the patients face a very rapid process of revascularization therapies. So our main focus is to identify those who have an unstable angina or a non-ST segment elevation infarct. And the majority of these patients even won't have any EKG changes. So we only have to rely on the clinical presentation of the patients and the biomarkers. And for this purpose, the introduction of high-sensitivity troponin assays has helped a lot to improve the faster and more accurate diagnosis of myocardial injury and myocardial necrosis in the setting of an infarct. And the introduction of fast protocols, namely the 0-0-1 hour protocol, or as an alternative, the 0 and 2 hour protocol, or in case these protocols are not feasible or available, then the 0 and 3 hour protocol. These are all protocols that are based on high sensitivity assays with validated troponin assays and pre-specified cutoffs and baseline concentration. So if you employ these fast protocols, you can accelerate the diagnostic process. You can have faster disposition of patients. So rule out patients who do not have an infarct, rule in patients with myocardial injury or an infarct, And then because these strategies are optimized to yield the most optimal result for both categories. So there's a category that's left over. That's the so-called observe zone.
Yeah.
And in this observe zone, this is, I think, one of the greatest challenges that we have is to find out who is then lower risk or higher risk, who will at the end have an infarct that we missed by the serial testing if we limit the numbers of tests. So this is a very interesting but very challenging group. But this is our daily practice to get the diagnosis, and this in the environment of crowding, of overfilled, overcrowded emergency departments, where we face a lot of entries and very often exit blocks.
I see. And I was thinking in terms of how these tools have changed the way, or how these algorithms have changed the way, or have changed your clinical practice. Can you explain us how it was maybe when you started your career and how things are now, and then maybe in a later stage we can look into what might be the future of these solutions practice.
So far, as I mentioned, there are several accelerated protocols, fast protocols that have been optimized to get categorization, a classification of patients faster. These protocols did not exist several years ago. So at that time, we relied on measurements based on the 99th percentile of a healthy reference population and some validated concentration changes that we deem to be relevant.
Yeah.
The introduction of the fast protocols assumes that troponin is released in a time-dependent way. So the longer you wait for the next blood draw, the higher will be an increasing troponin. So the concentrations that have been found to be relevant are time-dependent, and therefore all fast protocols have different baseline and concentration change values. For example, with troponin T, the baseline concentration for rule out is for 0 hour rule out is below the limit of detection. That is 5 nanogram per liter. If you use the 0 and 1 hour protocol, you should have a concentration, the initial concentration below 12 and the delta change below 3 nanogram per liter. And if you have a rule in, then your baseline concentration is above 52 nanogram per liter. Then you are already ruled in with the first blood draw, or you have a delta change of more than 5 equal or greater than 5 nanogram per liter. So that is rule in. For the 0 and 2 hour protocol, these values are different. And now we come to a problem. In the situation of crowding in the emergency departments, a fixed time point for the serial testing, let's say after 1 hour, an exact time point, exactly 60 minutes after the first blood draw, is not feasible because nurses, the staff is busy. They have a break. There's in general we have a staff starvation in German EDs. The physician is busy, so you cannot achieve an exact timing for the blood draw. And even the 10-minute interval, plus minus 10 minutes, that has been set and that has been written in the most recent ESC guidelines, is not feasible. 10 minutes is very challenging. So, and you cannot expect from the ED physician that he has all baseline concentrations and cutoffs for the delta change in his mind by heart. It's impossible to have every rule in your head. So usually hospitals decide to use one rule, one algorithm, let's say the ESC 0-1 hour algorithm, and physicians are trained on that. But if now the rule cannot be achieved then the interpretation is wrong.
Yeah.
And here now comes this tool into play. So a clinical decision tool, as any clinical decision tool, aims to help the physician with his decisions. And should I go now more into details of this tool? This tool is a so-called knowledge-based tool that merely incorporates what has been provided by guidelines and what is evidence-based on the established validated protocols. So the information that is contained in this CDS tool is, for example, which protocol are you following? Are you following a US protocol with US reference values, or are you following a non-US protocol? What is the time of chest pain onset, the last episode of chest pain? Then what is the time and the concentration of the first troponin value? And then this tool already gives you an output and readout that say, according to the ESC guidelines, with the first blood draw and the presentation time of more than 3 hours since the chest pain onset, you have troponin below LOD, so you have a rule out. You can stop your triage process. The patient is ready for disposition. He is either rule out or rule in, and you can make the decision to admit or discharge.
Yeah.
If not, the protocol suggests, the tool suggests a second blood draw and also proposes the optimal time point for the next blood draw. If you can fulfill that, then you insert the time when is the second blood draw, and the protocol automatically reads out what is the result, the classification zone. If by chance you did not reach the goal of having 60 minutes or nearby 60 minutes, then the tool automatically reclassifies the patient according to the nearest available protocol.
Yeah.
So, for example, you are closer to this 2-hour sampling time, then the protocol will give you the result of the ESC 0-2-hour protocol. If you're closer to the 3 hours, then it will give you adjudication based on the 0-3-hour protocol. And this ensures that you have the proper classification. You adjust for the time intervals, and this is something I think that's very important because it helps physicians to make a more accurate classification.
Yeah. And in the era of artificial intelligence and digital health, how do you see this tool, maybe in particular, and other tools evolving in the future when it comes to supporting these discharge decisions or respecting, the guidelines based on, the different thresholds and the evolving literature as well?
So first of all, I already see a lot of chances from the CDS tools to improve our daily quality of healthcare. Why? Because the tools correct for misclassification. Thereby, they allow reclassification. They also lead to a change in the prognostic assessment of patients. They change the risk group. They are transparent. The tool can show the physicians and the hospital how is their general performance regarding protocol adherence, and also guideline adherence, and may help to overcome some general problems.
Yeah.
So already here we have a lot of improvement. And probably it's also more cost effective because the tool avoids overdiagnosis, so means excessive blood draws that are costly, and also avoids, let's say, underdiagnosis because it alarms you when you need to have a second or a third blood draw. So this reduces the risk of missing an infarct by omitting a necessary second or third blood draw. Now coming to the artificial intelligence or let's say further development of this kind of tool. Of course, there is a very big chance for improvement, and artificial intelligence is in general a tool that helps us where we are not able to solve a problem by conventional biomarkers, by conventional statistical analysis. So it's a very helpful tool with big data and with complicated scenarios. And especially for the setting of acute coronary syndrome in the ED, I see many chances. For example, unmet needs for physicians is the better risk stratification of a patient. So after you classify the patient, for example, as rule out, you want to make the decision to admit or discharge this patient. Usually you do that by risk stratification that is based on gestalt, on your gut feeling, or based on a clinical score. For example, the Gray score, the TIMI score, the ADAC score, the HEART score. So there are many scores on board. But artificial intelligence could improve that risk assessment. So the tool combined with artificial intelligence could tell you, yes, this is rule out. The estimated probability for death or reinfarction within the next months is X%. Mm-hmm. So you can give a rough estimation of the risk of the patient. So, and the third is, for example, another unmet need is, for example, the estimation for the need of coronary angiography and revascularization. So such a tool would also give you information on the probability of having an obstructive coronary artery disease requiring revascularization, and then you can discharge the patient but plan for a readmission for coronary angiography and maybe for an invasive strategy. And so far, the tools that are available to do this are very limited. So there are some tools, but their performance is, let's say, imperfect.
Yeah, understood. There is always a recurring question we ask every guest on the podcast, and I think it goes in the same direction as we mentioned regarding the tool that you have developed and how you see it evolve. But the question is, if you had a magic wand or whatever, which digital solution would you like to have in your clinical practice that is not available today? Maybe something different than the tool we just discussed.
Yes. Well, first of all, I would like to have my tool because I think the implementation of such a tool is already a small challenge due to the interconnectivity, due to IT problems. To have this tool is already a big achievement. And then if one can have a very comprehensive tool that allows you, let's say, also discrimination on clinical grounds, what is high probability for an ACS versus a non-cardiac chest pain, or solutions that can help you in the sequence on deciding on risk and management, optimal medical therapy, to check for guideline compliance regarding secondary prevention, the need for coronary angiography, for revascularization. So this kind of comprehensive tool would be ideal.
Yeah. Thank you, Professor Giannitsis.
Thank you very much for having me here.
Thank you for listening to this episode of Cardio Insights. We hope you enjoyed it. If you want to dive further into other aspects of digital solutions in cardiovascular and emergency medicine, check out the other episodes of the series. To support the show, you can share this episode with your surroundings and leave a 5-star review on your preferred streaming platform. Cardio Insights is a podcast brought to you by Roche. Thank you for your time and see you in the next one.